Dear colleague, welcome to this introduction to DBS for essential tremor. This overview is intended as an introduction to the course on essential tremor. Please consult the course curriculum for details, and please note that there are many lectures on the website regarding different aspects of essential tremor, which do not form a part of this course. Essential tremor is hereditary in about 50% of the cases. The condition can appear in all ages, but onset is most common in upper middle age. The condition will normally start in the dominant hand and later spread to the other hand. Tremor of the head is quite common and is often considered as a problem. Tremor of the voice is not uncommon, but this constitutes a problem only in a few patients. Tremor of the legs is quite uncommon and seldom poses a problem. Essential tremor is a tremor of action, or more correctly, postural action kinetic, with a frequency of 7 to 12 Hz. Rest tremor is very uncommon. Over time, the tremor will progress and often change its character. In older patients with severe tremor, it often has a higher amplitude, a tendency to more proximal involvement, and an atactic component with more jerky movements. The tremor will in most patients respond well to alcohol and increase under stressful conditions. The patient will typically complain of difficulties eating, drinking, writing, etc. The social embarrassment of this condition is often perceived as disabling as the functional decline by the patients. Beta blockers are the first line of treatment. It is estimated that 50% of the patients will not respond well to pharmacological therapy, and we will start to consider DBS if beta blockers or primidone do not have the desired effect. Other medications are only tried if DBS has been deemed unsuitable. Patient selection is very simple in essential tremor. We consider DBS in patients where medical treatment has not been satisfying based on anamnesis and examination. Where there are no surgical contraindications, the patients should not be too old, they should have a reasonably healthy brain as judged from the MRI. They should be okay from a cognitive point of view and of course have reasonable expectations. The diagnosis is not complicated. Basically, if it looks like essential tremor, then it is essential tremor. Some cases where there might be difficulties are dystonic tremor. This is often mistaken for essential tremor when the dystonic symptoms are mild. Consider this diagnosis if the patient complains over pain in the tremulous limb and or in the neck and shoulders, or when there are dystonic posturing in the neck or in the outstretched arm. Another condition is task-specific tremor. Here the tremor only appears in one or a few similar conditions, such as writer's tremor seen here. Then we have Parkinsonian tremor. Sometimes patients with Parkinson's disease have a tremor similar to essential tremor, including action tremor. And some of these patients are just essential tremor patients who after many years develop Parkinson's disease. But in others, the onset of tremor and other mild symptoms of Parkinson's seem to be more or less simultaneous. Consider Parkinson's disease when there is even the least resting tremor or when there is a poor facial mimic. The good news is that DBS works as fine for dystonic tremor, task-specific tremor and Parkinsonian tremor as for essential tremor. Essential tremor is a cerebellar disease, and ataxia and affection of gait and balance are common, especially in older patients with more pronounced disease. It is important to be aware of such symptoms, since a unilateral procedure is preferable in patients with impaired gait and balance. Ataxia is not a contraindication for surgery, but it will probably increase the risk for stimulation-induced ataxia after surgery, and hence one might want to moderate the chances for an optimal outcome when informing the patient. Basically, I operate all patients who consider themselves to suffer so much that they are willing to undergo surgery, that have reasonable expectations, and where there are no contraindications. In most patients who are deemed not suitable for DBS, this is not based on one single contraindication. The typical patient who I do not suggest DBS has some cognitive decline, an MRI demonstrating atrophy and vascular lesions, is close to the age limit for DBS, and often has some other issues regarding his or her general health condition. When we have decided on surgery, we need to decide if we should perform a unilateral or a bilateral procedure. My opinion is that one should never perform a bilateral procedure for essential tremor if there is not a substantial tremor in both upper extremities or in the head. Bilateral procedures have a higher risk for complications, mainly dysarthria and disturbance of balance and gait. These complications are mainly stimulation-induced and hence reversible, but in older patients there might be a small risk for persistent non-stimulation-induced side effects, mainly affecting balance. 75% of my essential tremor patients have unilateral DBS. Below the age of 60 to 65, I consider bilateral surgery in one session to be acceptable. Between 60 to 70 years, I sometimes perform bilateral surgery in 2 sessions separated by at least 6 months if the patient and the brain are healthy, but in most patients I will recommend a unilateral procedure. Above 70 years of age, I never perform bilateral DBS for essential tremor. The next question is where to operate. We can enter this tremor loop either at the level of the thalamus in the VIM or at the level of the posterior subthalamic area. Here we can break the propagation of the pathological oscillations and hence the tremor by stimulating or by lesioning the cerebellothalamic fibers. So, where are these targets? Here we see the red nucleus and the subthalamic nucleus. The target in the PSA is often called the zona incerta, which is draped over the STN, gliding down over it in a posteromedial direction. According to the Schaltenbrandt atlas, we are targeting the caudal part of the zona incerta, while the target in the Morel atlas corresponds to the cerebellothalamic fascicle. Here we see the relationship of these structures to the ventrolateral thalamus. The VIM, seen here in yellow, is located in the ventrolateral thalamus above the ACPC line, and the PSA is located below, as seen here in the sagittal view. The PSA is more or less the area here encircled in red between the red nucleus and the posterior tail of the STN, as seen here in the horizontal view. If we look at the historical development, the first target for movement disorders was the pallidum, introduced in 1947. But the ventrolateral thalamus soon became the target of choice due to its better effect on tremor. And the thalamotomy naturally led to an exploration of the underlying subthalamic area with the introduction of a number of new procedures. The most important of these being the subthalamotomy introduced by Wertheimer in 1960. During the following years, thousands of patients were operated in this target by Leitinen, Munninger, Hudar and others. When we read the literature from this era, it is important to realize that the term thalamotomy was often used to encompass also the subthalamotomies, and many used combinations of these two procedures. A number of comparative studies demonstrated the subthalamotomy to be more effective than the thalamotomy, and it was used for Parkinson's disease, essential tremor, and other movement disorders. The thalamus and the PSA were also the first targets used for early DBS by Munninger and others. However, with the introduction of modern DBS by Benabid, first in the VIM and later in the subthalamic nucleus, the PSA was more or less forgotten. And thalamic DBS was proven to be a better option than lesions, especially when performed bilaterally, and DBS has today mainly replaced lesions, even if we now are seeing a revival for thalamotomies, especially with the focused ultrasound. But I believe that we are now seeing a renaissance for the PSA as a target for DBS. The scientific literature is still limited, but more and more centers are using it. In Scandinavia, it is commonly used and seems to be replacing the VIM. So, what is the target? Well, the target is in reality probably the cerebellothalamic fibers at the level of the VIM or at the level of the PSA. The reason why the PSA might be a better choice is that the fibers are here passing through a narrow funnel created by the STN and the red nucleus before dispersing into the overlying VIM. Since the fibers are more concentrated here, you will reach more of them with your field of stimulation than above in the VIM. Further, the funnel can be easily identified on MRI, while the VIM is identified based on atlas coordinates. Many different names are used for the PSA target, but when you look at the actual electrode location, you will see that these are in the same place regardless of which name is used. And this is hardly surprising, since we do not have that much freedom of choice. The target area is quite small and is encompassed by the STN, the internal capsule, the medial lemniscus, and the red nucleus. The target in the PSA is identified on a T2 MRI. We start by placing the cursor at the laterality of 12 mm, 7.5 mm behind the midcommissural point, and 4 mm below the midcommissural plate. This is the atlas target. We then identify where the red nucleus has its maximal diameter, and this gives you the set coordinate. At this level, we will identify the x and the y coordinates. Here, at the level of the maximal diameter of the red nucleus, we can identify the target directly, somewhat posteromedial of the posterior tail of the STN, or we can use some mental help lines. We identify the center of the red nucleus and make a line through this, passing at or in close vicinity of the tail of the STN. We then mark the medial border of the STN and the lateral border of the red nucleus and place the target on or slightly behind this line, somewhat closer to the posterior tail of the STN. In some elderly patients, especially with Parkinson's disease, the STN can be only partly visualized on MRI due to a low iron content. Typically, the STN appears to be shorter and to end more anterior due to loss of the most posterior part. The lateral border is often affected, as well as the most posterior part of the medial border. The anteromedial part of the medial border is typically intact, and this does not constitute a major problem when targeting the zona incerta. This is because the helpline we were discussing is passing through the center of the red nucleus, and it will typically pass at or in close vicinity of the posterior tail of the STN. Thus, a loss of the posterior tail of the STN does not affect this line, because it is not a line passing through the center of the red nucleus and through the posterior tail of the STN. And since also the medial border of the STN is usually well preserved more anterior, the target can be identified as described above. In the next step, we will make a trajectory and we'll choose an entry point within 10 mm from the coronal suture at the coronal angle as steep as possible, normally 30 to 45 mm from the midline, and neither sulci or ventricles should be transected. Most often I will be on the coronal suture or slightly behind it. In the final step, we adapt the trajectory to the STN if necessary. Concerning the VIM, we cannot see this why this structure is targeted simply by using the atlas coordinates. These can vary somewhat, but are typically identified at the ACPC plane, 13 to 15 mm lateral of the midline, and 6 to 7 mm anterior of the PC. And the trajectory is chosen as described above. It is possible to combine the VIM and the zona incerta if you want to. This is feasible in about 9 patients out of 10. In 1 out of 10 it is not possible to get a good trajectory for both targets. I think that it is wise to ignore the atlas coordinates of the VIM in those patients because the location of the cerebellothalamic fibers in the VIM are probably more accurately predicted by the closely related STN and red nucleus than by the very distant commissures. Here we have one such case where the trajectory for the VIM in blue is coinciding with the trajectory for the PSA in red. And as I said, in 10% of the patients the trajectories will not be coinciding as in this example, and it will be impossible or at least inadvisable to adapt the trajectory so that both targets are included. In those cases, we need to ask ourselves if we believe that the location of the cerebellothalamic fibers in the VIM are better predicted by the closely related STN and red nucleus or by the faraway AC and PC. Further, if we believe that the cerebellothalamic fibers are suddenly making a sharp turn just to follow the ACPC. My guess is that this is not the case and that we are more likely to hit these fibers in the VIM by targeting the PSA. Another option used by some is tractography-based targeting. This seems reasonable if we are targeting a fiber bundle. However, this method is still in its infancy. It is uncertain how much we can trust what we are seeing, and the accuracy of the merge can be a problem with the DTI sequences and the actual MRI sequences used for calculation of coordinates. And those using tractography seem to end up with the electrodes in the same place as we do when targeting based on the red nucleus and the STN. Another question is, do we need microelectrode recording to identify this target? Unfortunately, I can't answer this question since I have never tried microelectrode recording. Regarding intraoperative macrostimulation, a problem with the PSA is that the stimulation response is often difficult to interpret if you are not familiar with this target, due to a pronounced microlesional effect on tremor and stimulation-induced side effects with rapid adaptation. This is side effects seen at first time of stimulation, mainly during intraoperative macrostimulation, and then never again, or only at higher stimulation strength. Pronounced paresthesias with rapid adaptation might appear during the first stimulation session. Often, paresthesias in the PSA take a longer time to fade away compared with the VIM, so some patients might be required when testing the patient. And paresthesias have never compromised the result in our experience. Regarding dysarthria, if the electrode is correctly placed, this is not caused by affection of the internal capsule. It is caused by affection of the cerebellothalamic fibers in or close to the target itself, thus it is an affection of the coordination of speech. This might be a side effect with rapid adaptation as described above. If the electrode is correctly placed within the target, we will not move an electrode even if the sartre is seen at low voltage. But note that a too lateral placement of the electrode in the internal capsule can cause dysarthria without adaptation, hence the importance of verifying the position of the electrode. In our experience, there is no deterioration of speech with chronic PSA DBS. Blurred vision is a rare side effect. This has only compromised the result in one patient where I misplaced the electrode. This effect is typically seen when the contact is located at the border of the red nucleus in its more anterior part. Bilateral or ipsilateral hyperhidrosis is sometimes seen, but this occurs at voltages above what is normally used for therapeutic stimulation and typically at one single contact. It occurs at electrode contacts that are well placed within the target area, and it has never been necessary to move an electrode due to this side effect, and it has never compromised the result. So, what do we do if we do not see a tremor reduction when stimulating? Well, to be honest, in patients with essential tremor, dystonic tremor, or Parkinsonian tremor, we have never failed to get a good effect on tremor during intraoperative stimulation when the electrode was in the correct target. If you do not have a good effect and the electrode is outside of the blue area seen here, then we would relocate it to the target point within the blue area. If you do not have a good effect even though the electrode is within the blue area, then we have no suggestions for relocation of the electrode within the PSA. Thus, the PSA can be implanted based on the anatomy alone, and intraoperative macrostimulation is hence not necessary, only intraoperative verification of the electrode location using CT and MRI. Regarding the VIM, since we can't see this target, it is necessary to confirm that you have ended up in the right area, why macrostimulation is of value. Note that transient tingling deep in the hand, not in the fingertips, and along the lower arm is a positive sign suggesting a good location of the electrode. Relocation of the electrode based on stimulation response is done in the following manner. When we see non-vanishing paresthesias in the fingertips or around the mouth, then we will move the electrode 2 mm more anterior. Vertigo or nausea is often a sign that the electrode is too deep, and we would retract the electrode 2 mm. If we have no or a poor effect up to stimulation with 3 volts, then we would explore the subthalamic area 2 mm and then 4 mm deeper. If still poor effect, then we increase the stimulation until side effects. If capsular side effects, that is motor or dysarthria, then move the electrode 2 mm more medially. If sensory side effects, move the electrode 2 mm more anterior. We then come to the results of DBS for essential tremor. When reviewing the literature on DBS for essential tremor, it is surprisingly difficult to compare different studies due to different targets and uncertainties where the electrodes were actually located. Some studies compare on DBS with a pre-operative baseline, while others compare on versus off after surgery. There are differences in the length of follow-up, and different scales are used, and the outcome is reported based on different items from these scales, alone or in various combinations. However, The experience of DBS for essential tremor seems to be rather uniform, and there is a general consensus that DBS constitutes an effective and mostly well-tolerated treatment for essential tremor. For more details, there are several scientific reviews available, like this one from the group of Lozano in 2019. I will here attempt to give an overview of the results to a large extent based on my personal experience. Regarding the different targets, there are some mostly circumstantial evidence suggesting the PSA to be a better target than the VIM. The published studies on PSA DBS seem to compare favorably with the studies on VIM DBS concerning tremor reduction and energy consumption. There are further a number of studies analyzing where the best effect is achieved in what is called VIM DBS, and this is most often achieved below the VIM in the PSA. And these studies were done in patients where the VIM was targeted, and we will of course achieve a better location of the electrode in the PSA if we target this directly instead of using the atlas coordinates for the VIM and push the electrode somewhat deeper. There are two longitudinal single-center comparisons between VIM versus PSA, both reporting better outcome in the PSA. And further two reports on improvement after target revision from VIM to PSA after failed DBS for tremor. There are a couple of publications on combined targeting of the PSA and the VIM. And recently a third study on 13 patients implanted with one electrode in both VIM and PSA. And data from this randomized, double-blind crossover trial in essential tremor suggest that the PSA is at least as effective as VIM DBS, but more efficient in reducing tremor, with no disadvantage regarding stimulation-induced side effects. And the authors concluded that implantation of DBS leads into the VIM only no longer seems advisable. I would like to end this presentation by a short overview of our experience in Umeå concerning DBS for essential tremor, where we have implanted about 80 patients in the VIM and more than 120 in the PSA. Today we do all procedures in the PSA based on visual anatomical targeting and without microelectrode recording or macrostimulation. The whole procedure is done with the patient asleep, and the tunnelation of the extension cable is done with the frame in place. We started with VIM DBS in 1993, and the results were quite satisfying initially, but over time the effect of the stimulation decreased significantly at the same time as the energy consumption increased. For that reason, we changed our target to the zona incerta in 2004. When we compared our last 34 VIM DBS with our first 34 PSA DBS, we had a 70% improvement of hand tremor and function in the former and 90% in the latter. And here we see the result in a middle-aged man with bilateral DBS before surgery and after surgery. And here we have another example. This is an elderly left-handed gentleman with unilateral DBS, here seen before surgery. In younger patients with a more modest tremor, it is often possible to remove virtually all of the tremor. But in the older population with more severe tremor, with higher amplitude, there will often be some remaining tremor. We see that the patient is trying to pick up the glass, but it is virtually impossible. And here we see the same patient after surgery. We see that there is a considerable improvement of the tremor. The patient is very careful, and often it will take the patient quite a long time to start to trust the DBS. As they often say, it is difficult to learn not to have tremor. We have also looked at where we achieve the best effect of stimulation in our patients, and this is in the small area seen here in blue, between the red nucleus and the STN, and this corresponds well with our intended target. Importantly, the effect is maintained over time in the PSA, and the energy consumption does not increase over time. The energy consumption is further very low compared with what has been published for the VIM. Regarding age, I have previously believed that the results of DBS are better in young patients with less severe tremor. When I analyzed our result from 68 patients, this was in some way correct, but in another way incorrect. The following data was obtained. Age and severity of tremor were not correlated to the relative reduction of tremor on stimulation. Older patients tended to have more severe tremor than younger patients. And patients with more severe tremor before surgery had more residual tremor on stimulation. And older patients and patients with severe tremor had the same beneficial effect of stimulation, the same relative reduction, as those with less severe tremor and younger patients, but they would not reach the same low level of postoperative tremor. Minor ipsilateral effects have sometimes been reported in the literature, and the group of Åkun suggested that this should be taken into account when considering unilateral or bilateral surgery. However, these effects are very small on the group level and have, as far as I remember, only reached significance regarding hand tremor and never regarding hand function, so this is very questionable. Anyhow, we looked at this in 49 patients before surgery and then on and off stimulation at 1 year and after 3 years. Some minor effects seem to be present, but nothing that would affect our decision to do uni or bilateral surgery. It is true that in a few patients the ipsilateral effect was rather pronounced after 1 year, but less so at a long-term follow-up. There is not much published regarding essential head tremor. Most often a mean score is presented, including also all the patients without head tremor, why it is difficult to form an opinion on how effective DBS is for head tremor. Further, it is a common belief that bilateral DBS is necessary in order to have an effect on head tremor. We looked at unilateral DBS in 17 patients with essential head tremor before surgery and at follow-up after 1 and 3 years. In mean, head tremor was reduced with 88%, from 1.7 points before surgery to 0.2 at both short and long-term follow-up on stimulation. At baseline before surgery, 8 patients scored 1 point on head tremor, 7 scored 2 points, and 2 patients scored 3 points. On stimulation, 4 patients scored 1 point and the remaining cohort showed no head tremor. Regarding voice tremor, the situation is similar, with most often the mean score being presented in the literature, including also the patients without voice tremor. It is also common that people believe that bilateral surgery is necessary for relief. We looked at 19 patients with voice tremor before unilateral surgery and at long-term follow-up. Here, tremor was reduced with 67% on versus off stimulation after 5 years. The effect is, however, heterogeneous and varies between different patients. Here we have two examples of the effect of unilateral DBS. Before surgery and after. Here we have a more modest effect before surgery and after surgery. We also looked at voice tremor in 7 patients with bilateral DBS, and interestingly, unilateral left-sided DBS was as effective or even more effective than bilateral DBS in 6 out of these patients. We then come to the question whether to do the procedure with the patient awake or asleep. A sleep DBS is common concerning the GPI, the ANT, and psychiatric targets, and the question today mainly concerns the STN and especially thalamic and subthalamic DBS for tremor. There is so far only one study regarding a sleep VIM DBS for essential tremor, demonstrating no differences between asleep and awake surgery. Unfortunately, this study has several limitations. The patients were implanted awake or asleep based on their personal preferences. 40 awake and 17 asleep patients were given a questionnaire regarding tremor ADL, but only 60% of the patients responded. In that questionnaire, the patients assessed their tremor status both before surgery and at present, which was 4 to 31 months after surgery. There were no differences in outcome between the awake group and the sleep group. In Umeå, we have done all PSA DBS procedures for essential tremor asleep since 2011, and we have here compared our last 30 asleep procedures with the first 30 awake. The groups were very similar, and we could not see any significant differences in tremor reduction between awake and asleep DBS. However, when we looked at the stimulation parameters and the energy consumption, this was significantly lower in the sleep DBS. It is possible that this is reflecting a better electrode location, but it is also possible that this is due to other causes. We then come to complications and side effects. There are the same surgical risks as for DBS in general. There are few complications of a serious nature in experienced hands. The most common problem is reversible stimulation-induced side effects, as discussed above and in further detail in the lectures on programming DBS in the VIM and in the PSA, respectively. We have some problems that are quite specific for DBS in essential tremor. Rebound of tremor, that is, increased tremor after turning off DBS, was often seen in our patients with VIM DBS, but very seldom after PSA DBS. Almost all patients will have a good tremor reduction during the first months after surgery. Our main problem with PSA DBS is that in approximately 10% of the patients we will see a poor effect over time. This problem was more common in our patients with VIM DBS. In some patients, this might be due to a progression of the disease. In others, it is due to development of tolerance with increased stimulation strength over time. Eventually, this might lead to a poor result when the stimulation cannot be increased further due to stimulation-induced side effects. At the group level, we have not seen any development of tolerance in the PSA. But in individual patients, we have encountered a deteriorating effect with increased demand of higher stimulation strength. This should not always be seen as tolerance, but as we are driving the tactic component. Ataxia is confusing, at least for me. Ataxia is often a component of essential tremor, especially in old patients with severe tremor. DBS will often have a good effect on what I perceive as an atactic component, but only in the short term. DBS in the PSA or in the VIM might also cause or increase ataxia. And ataxia can be a side effect with rapid adaptation. When ataxia is seen during macrostimulation at surgery at low current, there will normally be a rapid adaptation within days, and the current can gradually be increased without causing this side effect. Over time, the main obstacle to a good result of DBS in essential tremor is tolerance and ataxia. This is mainly the case in older patients with severe tremor where ataxia is a component of their disease before surgery. Ataxia is sometimes misinterpreted as tremor, especially but not only by the patient, and the patient therefore wants to increase the stimulation strength to improve the result. This might, however, in reality increase the ataxia, leading to further demand of increased stimulation strength and declining effect. In these patients, it is important to identify the atactic component and to inform the patient about the nature of the problem. In such patients, the best thing is to start at a lower level of stimulation where ataxia is not induced, and only to use the stimulation when needed. In severe cases, as we used to see when we performed the VIM DBS, a stimulation vacation of a couple of weeks might be necessary. This will often have a stunning effect. Reducing the pulse width to 30 microseconds might be beneficial in some patients. If using directional leads, it might be beneficial to move the field of stimulation in a lateral direction, since ataxia might be caused by affection of fibers close to the red nucleus. The most important thing in these patients is to be satisfied with a good result and to abstain from trying to get a perfect result. Martin Reich has looked at stimulation-induced gait ataxia, which I must admit that we have never seen, perhaps because our patients turn off the stimulation overnight. Here his group has demonstrated the beneficial effects of a stimulation vacation, further of using a lower pulse width, which might increase the therapeutic window. We have also tried lowering the pulse width in our patients with upper limb ataxia, but unfortunately with limited positive effects. Reich suggests that ataxia might be caused by stimulation of a more medial fiber bundle closer to the red nucleus, and this might be correct. Here we have one of our patients where I misplaced the electrode too close to the red nucleus. When stimulating in ring mode, we were unable to achieve a good effect on the ataxia. With anterior stimulation, we did not see much effect at all. In the posterior medial direction, we again got ataxia, but when moving the field of stimulation posterolaterally in the direction of the intended target, we achieved an excellent result. The new directional leads are a tool which might prove to be useful in essential tremor. At least we are using the directionality in 70% of the 35 essential tremor patients we have implanted with directional leads, and in at least one of these a good outcome was not possible to achieve with stimulation in ring mode. If you would like more information regarding DBS and essential tremor, please visit the Stereotactic Academy at stereotactic.org. This is a free e-learning resource with more than 140 lectures on stereotactic functional neurosurgery, courses and other material. And with this, I thank you for your attention.